Yeah.
Yeah, point at it and pull the trigger like a gun, and see if that works.
I can't move it.
I'm joined here by my colleague, Dr. Muhammad.
Hi, everyone. Well,
They want to look good. They want to feel great. They want to feel great. They want to live on time. They want to. That means that live on time. They want to. That means that they want weight loss and they want to have better matrix for healing to for product is the PRP. That this white fluffy layer that is between the layer and the red layer. Female sexuality. All right. So we're going to start with the female first because women always come first, right? But there and her husband now are having intercourse at least 3 to 5 times a week. So within 3 weeks of PRP treatment for this lady, for this patient in her vaginal area, you're able to transform their life and not her life, but her husband as well. So this study showed that that sexual dysfunction is an important for your health and your emotional state. All right. And that feminine health issues is an $83 billion business in 2020 because women have issues of menopause, which is hormonal imbalance, and vaginal tissues, which related to childbirth, such as vaginal laxity, pain, lubrication problem, vaginal atrophy, secondary to menopause and childbirth, urinary incontinence, meaning that every time she laughs or cough or exercise, she loses urine. All of these issues you see right here can be treated with PRP and hormone. All right, treated. All right, and reversible. So no woman should be suffering from urinary incontinence. No women should be suffering from pain in the vaginal area. It can be treated. I hope that you all hear that. I hope that you tell everybody you know about it. I see women here. I'm looking around. You should not be living with any pain. If a man, you have a partner, please know that as well. 15, at least reported right now, 15 million women are suffering with urinary incontinence as well as postmenopausal atrophy and dryness, and this is treatable. All right. So female sexual dysfunction is very prevalent, but yet only 14% of women talk to their doctor about it because maybe they feel embarrassed, maybe they feel shameful, maybe they don't know that there are treatment options available. And of the active female population, 40% experience sexual difficulty. And the review of the treatment options is psychological or testosterone. And there are 4 classes of sexual dysfunction. It's hyposexual disorder, arousal disorder, orgasmic disorder, and dyspareunia. All of this can be treated with hormones and PRP. The brain is the largest sexual organ. Now, are you surprised by that? I'm looking around. Can you raise your hand? Can you raise your hand, those hands? I'm looking at you. Is that a surprise for you to hear that the brain, not your genital, is the largest sexual organ? Raise your hand if you find that something new. Yes, I see Dr. Gaddis. Yeah, Dr. Omar. All right, great. Because it is the largest sexual organ. Nothing happens below the belt unless your brain is involved. All right, thing. Not your penis, not your vagina, in the brain. All right, so you got to, because of that, you got to pay attention to that.
That's why I became a neurologist.
You should be the sexual expert because you're the brain. And I just said before, I said no woman should be living with pain, all right, or discomfort with intercourse. It can be treated. All right, number 1. So the brain is the largest sexual organ. So in order for a woman to get aroused or a man to get an erection, somebody's moving my slides. All right. In order for a woman to get aroused or erection, it starts in the brain. It's number 1 here in the top. And then you have to be in the mood. So that's why the emotion, you have to feel in the mood. You have to be relaxed. And then the hormones are being released in your brain. And then the hormones stimulate the nerve in your spinal cord and the nerve chain that goes down your spinal cord called the parasympathetic and sympathetic nervous system. and then that increases, relaxes the blood vessels, so you can have more blood flow, and then that goes to the muscle, which is number 6. Again, the brain is the largest sexual organ. All right, it starts in the brain, and it doesn't go anywhere unless the brain initiate the process. So what this slide shows is that sexual desire, arousal, orgasm, and satisfaction of intercourse can be measured in a woman by a test that is called female sexual function index, FSFI. All right, you can Google this and get this test done. It is a test of that scores all the way up to 36, and a score of 26 or less is a diagnosis for a female sexual dysfunction. All right, so I put in this slide not to show you, but to show that for a female, a lot of it is due to interpersonal relationship and psychological, as well as social cultural influences contributing to the female sexual dysfunction. That is 3/4 that override the physiology. Yes, there are physiological component that may contribute to the sexual dysfunction, but a lot of it is 3/4 of it due to partner performance, lack of a partner, and relationship quality. All right, so for a woman, that she needs more of that connection with her partner. She needs to be in a good emotional state than a man. All right. Female sexual physiology, sexual arousals and orgasm is a vasocongested, meaning that the blood vessel has to open to get and dilate to get more blood flow down the vaginal area, as well as a nerve and muscle component, like just exactly like I said in the circle diagram. It's also under autonomic control, so parasympathetic nervous system. It again starts in the brain and it goes to the vagina area, and is involving the parasympathetic nervous system. The G spot was described by a German psychologist, and this is the erogenous zone that's in the anterior wall of the vagina. I'll show that later, and it's just located halfway between the pubic bone, the cervix, and it's part of the clitoral vaginal network. All right, so that's why we have this a model, 3D model, beautiful 3D model on the clitoris. Looks like a wishbone. All right, it is 4 inches long, 4 inches. Now, James, if you can point to the area that looks like a bulb, like an upside down V, you can point to that right there.
You're putting him on the spot, Dr. Truong.
Yeah. All right. So there you go. So no, the lower it looks like a bulb right there. The clitoris right there in front. Yep. So the upside down V there. That's actually the bulb of the fistula. That's part of the clitoris network. All right, and that the clitoris is not just that little knob that you see superficially. So men and women, this is what the clitoris looks like behind the skin of the vagina. All right, so that's what the red part is what you see. That's the outside, but it goes all the way deep inside, and then it's split to like a wishbone right here. That kind of goes along the labia majora. All right, and the bulb here that you see is actually right next to the labia minora. So for a female, the erogenous zone is throughout the whole vaginal, the vulva. The whole entire vagina area, just not the clitoris, it's just not the opening, it's the whole labia majora area. And the clitoris is the only organ that is purely for pleasure for a woman. So you have this for pleasure. That is its only function. You're not using it. That is a shame. All right? Because right here, it's a bulb. I'm trying to touch it. I may have moved it. I'm trying to touch it right there. It's a bulb. So what I'm trying to say, compared to a man, there you go. All right. Yeah, so this is the bulb right here. All right. But anyway, that's okay. Compared to a man, the penis in a man does 3 functions. It's for him to urinate and for ejaculation, the seminal fluid, as well as for an erection. So for a woman, the clitoris is a pure sexual function. If you're not using it, then you're not using one organ in your body. And you need to use it frequently. All right, on the left here is a picture of the penis. We'll get to that when we get to the male anatomy. But I want to show is that, Dr. Gaddis, if you can bring the male 3D male model up, is that the woman has a penis too. So the clitoris is a woman's penis. All right. So if you compare, so the tip that you see for the clitoris, that's the glans for a male, and then the corpus cavernosum is the corpus cavernosum of the female. So you can see that in the picture. The corpus cavernosum is that wishbone that's going down. That's the woman corpus cavernosum. That's the man corpus cavernosum, which is the shaft. And then the bulb, all right, the man also had the bulb, which is the corpus spongiosum at this point. So now you know the anatomy of the that looks like that. All right, how was that? Everybody enjoyed that? Okay. All right, very good. That was the clitoris. All right, so this is the G spot. The G spot is the area between the urethra and the anterior vaginal wall. And I have another picture that shows that as well. This picture just shows the clitoral vaginal complex. What that is that the clitoris is intimately involved in the bladder junction, in the vaginal junction. So it's not just an organ that is alone. So when we do PRP treatment to the vaginal area and inject into the clitoris, you're also injecting PRP that is also going to the bladder. So it's not to the vagina area, it's also affecting the bladder. All right, so here's a picture. And this is a picture of a woman that's being kind of cut in half in the coronal. It's also in the vaginal area. It's also helpful with mesh pain. I see this a lot in women that have bladder mesh that has neuropathic pain. More studies showing intravesicular injections with PRP. This study of vulvovaginal atrophy in patients that undergo chemotherapy from breast cancer because they cannot take hormones and their menopause. So these ladies are the ones that are suffering because they cannot take hormones. They don't have any lubrication. They have vaginal atrophy. But Lord and behold, PRP does help. All right, let's talk about the man. All right, Cody. All right, that's just I do what I do when I look at something that remind me of what I do. I take a picture of it, and this is in Moab, Utah, Arches National Park. So the man penis is the marvel of engineering. The penis is capable of increasing blood flow by a factor of 40 to 50 times over baseline within seconds. All right, and this is my patient Ed. He is 80 and they want to be able to have sex again. He wasn't able to get an erection. He come to see me and go, you know what, for 17 years, my wife was not interested. My wife passed away. I now have a girlfriend. I want to be able to have sex again. Can you help me with that? And therapy and shockwave therapy, as well as hormone, his penis size by an inch as well. And he gave me a great testimony that ED means that you cannot get an erection. That is not ED. Is defined as inability to have adequate nutrition. And then you can pick up ED by the test called the International Erectile Function. And I'll show you that test later on. So what is ED? It's persistent failure to generate sufficient pressure to a degree of penile rigidity until ejaculation. And ED is a smooth muscle problem and is also a small blood vessel problem. The prevalence of ED, the bottom line for COVID from the middle, will probably increase quite a bit. And this is a classic study that was actually done in, somebody needs to repeat the study. But what it shows is that ED increases with age. So at the age of 50% of men have ED, and at 60% of men have ED, and 70. If you have an erection right now, that means that all four system is working if you have an erection. That's why ED is so common, because if these four systems are not working well, you're not going to be able to get enough. And that erection, that ED, if you, it's about 90% of cases are physical, not psychological. It's only 10% is psychological. All right. Again, what the slide shows is that just organ involving the brain, your emotion, the hormones, the nerve, the penis. That's why it's a PD5 inhibitor. It increases more cyclic GMP, and therefore the smooth muscle of the penis relaxes. But when you take Viagra, you're essentially hijacking the erectile, the natural erectile response that you have naturally. So your body creates an erection from where? It starts in the brain. So when you take Viagra, you bypass step 1, step 2, step 3, step 4, step 5. Just go straight to step 6 to get that happens. So when you do that, what happened? After a period of time, your body will forget how to activate step 1 to step 5. And then after a while, your body is not responsive to the medication anymore, because the root cause of why you have ED has not been treated. Viagra is like taking opioid pain medication for pain, because you're just treating the symptom. You're not treating the root cause of the problem. It happened because of blood flow problem, but the blood flow problem is more proximal. The reason why you have decreased blood flow is I'm just going to skip all these slides right here. The reason why you have the decreased blood flow is because of high diabetes, high cholesterol, obesity, stress, inadequate sleep, smoking, and recreation. And again, this is CNS stimulation. That's the brain. So this is why ED medication do not treat ED, because it's hijacking your natural response to have an erection. Did everybody get that? I hope you learned from that, because it's really here. Due to caused by insulin resistance or diabetes, dyslipidemia, hypertension, and inflammation or obesity. And then the metabolic syndrome contribute to testosterone deficiency, which then cause sexual dysfunction. And then, of course, testosterone deficiency, you have atherosclerosis as well as vascular stiffness, which then overall mortality. And that atherosclerosis is also related to, and vascular stiffness is related to metabolic syndrome. So what I'm trying to say is that sexual dysfunction really modified if you work on the cause of it, which is diabetes, high cholesterol, high blood pressure, and inflammation and obesity. All right. So why does the blood flow affect the penis? Create ED first, because the arteries of the penis artery is the smallest in the body at 1 to 2 millimeter. The arteries in the heart, which is 3 to 4 millimeter, and then the internal carotid artery, which is the artery that supplies the brain, is 5 to 7 millimeter. So if you start to have ED, that means that you already have blood flow impairment that in the penis, which is a warning sign that the next step will be involving the heart, and then followed by stroke. Testosterone. So sexual vitality can be maintained even to the day you die. So this study just showed that that E is related to coronary event. So if you have ED, you're more at risk for coronary event. And that what I'm trying to say is this study is showing that ED is multifactorial. The most common cause is vasculogenic disorder, and that 30 to 40% of patients that with ED may not respond to Viagra. All right, so that's why they don't respond, because they have blood flow insufficiency. But that's unfortunately the first that prescribed for a man with ED. Nobody says or the other medication. And that ED, these are the different causes of ED. It's vascular, metabolic, vascular, metabolic, neurologic, and local penile tissue, hormones, drug-induced, psychogenic lifestyle and other condition here. And that PRP is safe and is good for the genitals. These are sessions and a score of 5. And if you score 22 to 25, you have no ED. And if you score 17 to 11 to 16 is moderate ED. So all the men in here, I encourage you to take this test. I'm turning around looking at people. Take this test. All right. It's available on Google. I don't know if you guys have access to this slides later on, but it's called the IIEF -5 test. And score is what your score is, and answer this according to the last 4 weeks without medication. All right. So this study shows that PR practitioner Tunica albuginea also improve the curvature. I do this under the curvature. I do this under ultrasound guidance. The area, and it breaks down pathologic deposit. That's why it's very helpful for Peyronie's disease, and also helpful for ED because it breaks down plaques in the blood vessels, and these cavitation create stressors, which the end product is neovascularization. And this slide here shows how shockwave therapy is helpful for ED because it produces more angiogenesis, it reinnervates the nerve, it recruit more stem cells, and it also remodel the muscles of the penis as well. And these are multiple studies. It's helpful for angiogenesis for ED. And I want to remark that all the studies that you see here are based on the no study having the radio demonstrate effectiveness. So all the studies that you see, so some officers and some vendors say shockwave therapy. There are multiple shockwave therapy, shockwave machine that uses electrohydraulic, electromagnetic. All right, slide just got moved. It's helpful for pain therapy. Shockwave therapy, an area that we also treat with shockwave for nerve regeneration as well as blood flow. All right, so this is a fun thing I added in on here. So, Bio in 2015 looked 6.1 inches and increasing your senses, meaning that when sex doesn't necessarily mean penetration, doesn't necessarily mean orgasm. It can mean just pleasurable senses and not based upon performance. And that social support from your partner and communication is vital. And exercise is with using high intensity interval therapy and having sex frequently, 3 to 5 times a week is good for ED, because once it starts working again, you need to use it more, because you use it or you lose it, right? Because the penis as well as the vaginal tissue is the muscle. The more you use it, the stronger it gets and the better sensitivity. But you don't use it, it's going to have atrophy. All right. So these are the slides on here for references: L-citrulline, L-arginine, picogenol, maca, Panax ginseng, and tonkat ali, as well as ginkgo biloba and horny goatweed. It's helpful for sexual health. And my presentation, thank you for being here, and I'm ready for questions.
Wow, Dr. Truong, that was really an incredible presentation. And I think it was very unique because in the past we've had such such specialized, topics, but this is something that everyone can relate to, whether or not you're in medicine. This is really incredible. And I came into this thinking I knew quite a bit, and I was humbled, admittedly very humbled. So thank you for that.
Well, thank you. That is my objective, is to have everyone come out of here and be well and learn something.
So my question is, when you're approaching ED with male patients, and let me come down a little bit closer to you here. When you're approaching treatment for male patients who have ED, and you're talking about injecting, PRP into the different structures of the penis, I imagine you encounter a considerable amount of apprehension. The thought of an injection into the penis is probably not the first thing on my mind when I think of performing better. How do you approach that conversation with the patient? Am I on mute? No, I'm not mute. Oh, I think we lost our guest speaker. There's a good chance that maybe the battery of her Oculus is dying.
That's probably true.
Okay.
I think what we should do, Dr. Gaddis, I'm going to unmute some.
Hey guys, how are you? I actually had a question that the doctor is done. So maybe I just
sorry
dropped
about
it.
that. I think
There's
it's a
no
good
problem?
opportunity just to hear some feedback from you guys on how you thought that sure went, and what do you think of this for our first timers here. What do you think of the new stage? And sort of.
Actually, Mo, I think Andrea was trying to ask an actual question.
No
Go ahead and
problem.
ask.
Give me feedback. There's no problem with that. Well, actually, the stage looks pretty great. The models are amazing. Actually, I don't know how you find those models, but they look great, and they were awesome for this topic.
Thank you.
Yeah, it was really cool.
So what we can also do is we can have you guys send any questions that you have directly to our email address, and our project manager Juan will provide everyone with our email address if you don't already have it, and we can forward those directly to Dr. Truong and have you get a personalized answer for everyone.
In fact,
we're pretty active on social media as well. So we can always, we can actually do some common questions asked and answers, since this is definitely a topic that's new to a lot of us in terms of the technical aspects.
In fact, immediately after this event, we actually will send a survey to you guys that has some general questions. And one of the questions, it asks like, what would you like to hear about? And there's a free text place. So if you have questions, you can enter it all in there, and we immediately get all those questions, and we can get it from Dr. Truong and blast it back out to you guys. Because I definitely had like at least 5 or 6 questions off the top of my head, but I think her battery died. So I'm just as curious as you guys.
Well, actually, I was really surprised with her patient, the one guy that was almost 80 years old, having sex 3 or 5 times a week. It was like, oh my God.
Yeah. I mean, good for him. Round of applause for that guy.
I actually was really curious about if she had any experience with patients who were transgender, and what that, what their questions may have been, what their issues may have been, and how she approached them. But these are awesome questions. And again, if you guys we're on pretty much every social media platform. We're pretty active on Instagram. So give us a follow. And I think we'll do common Q&As there. You can also DM us on Instagram and ask your questions there, or just leave a comment, and we can get your answers directly from Dr. Truong.
Hey, if everybody wants to turn
she's
around.
back.
Yes,
That's
Hey, back
Yay.
again.
Dr. Truong, we have questions for you.
Yeah, I know. I'm coming up. All right. Sorry about that. Of course, I ran out of power. So thank you for hanging out, being patient.
No problem.
All right.
Problem.
Who's asking questions? Apologize for that. But I'm here. I'm already all ears for questions. Okay, so you
Mo.
were asking Dr. Gaddis a question of apprehension for a man if he gets an injection
Yes.
down
How do you
there?
approach that conversation? Yeah.
All right. Well, first of all, I tell them that, I'm a pain management doctor. We put a numbing cream, but we also do a nerve block. We do a pudendal nerve block where they feel nothing. They literally, it's like as if you go to the dentist and he numb you up and you feel nothing. So injection, you have to reassure them that they will feel nothing. We also have nitrous oxide gas as well for them to relax. So it's all about, reassurance and giving a great Alexa in the room that play relaxing music and aromatherapy with lavender as well. So it is a painless procedure if you do a great pudendal nerve block and set seance. Is that pretty? Is that the answer you were looking for?
Yes, I didn't know that you do a pudendal nerve block. That's actually, I didn't even think about that. That's a great idea.
Yep.
And so
That's why it's good to be a pain management doctor and doing. I believe all pain management doctors should think about doing sexuality because you already doing regenerative medicine is really, instead of putting in the knee or the spine, you're putting into soft tissue, which has less side effects. It has less risk. I would tell you, I now 80% of my treatment is on ED and female sexual health, because I have pain now with putting on my metal jacket, and it just takes too long to prepare the room for spinal injections. And I mean, I did my fellowship as well too, and the amount of time that I do to treat an ED case, it's about 1/10 of what the time that I would do if I was going to do a facet block or a discogram or an epidural. So for me, time and my staff time and the room usage, it's a no-brainer.
Wow.
So if you're doing regenerative medicine for pain, you should consider going just a little bit below the near the belt region, the groin area. It's a lot safer injection.
I totally agree. And that makes sense because, the conversation I have with patients every day is, I might not get rid of your pain, but I'm trying to increase your functionality and help you enjoy life. And what's more enjoyable than having great sex again?
Exactly.
So I feel like you might overlook your back pain if you're able to make good love again.
Well, remember, also sex also decreases pain too. So when you're having sex and all the hormones and the neurotransmitters that's being released, it also decreases pain and improve depression and improve overall happiness. And as you know, you're in the pain management world. If patients have less depression, then their pain perception is also improved, right?
I agree. Dr. Truong, so I pulled the model up here. If you don't mind, would you be able to come a little bit closer and kind of gesture to me, just kind of point where you would typically...
Okay, where am I? Where are you? Am I underneath it? Okay, here we go. So am I supposed to
Yeah, you can
touch
just
it?
point with your hands.
All right, here, right? Can you see that? So the injection for the PRP will be here, and it's corpus cavernosus. In two area here, and then at the base of where the pubic bone meets, 1/3 proximal. 1/3 distal, 1/3 from the glands, 1/3 proximal, and then you also inject the glands as well. So and this is called the coronal part. So injection from here at around like 3 o'clock all the way to about 9 o'clock in the coronal area. So that's where the PRP injection with 10 cc's of PRP. But I get out if a man has comorbidity of low testosterone or or is above 65, I get 120 cc of whole blood rather than 60. And then we do a pudendal nerve block. Let me come closer. We do a pudendal nerve block like right here at like 1 o'clock and 11 o'clock at the base of the penis, injecting about 2 cc's each side with 2% lidocaine without epinephrine.
Wow. Okay. That's incredible. Thank you.
Yeah.
I think Mo had a question about some unique patient populations.
Yeah, I believe I'll wait for Andrea. I believe Andrea had a question that she was eager to ask you. She's
All
right
right, where's
behind you.
Andrea?
Yeah, I'm here. Hi, Dr. Truong. How are you?
Good.
Well,
How are you?
fine, thank you. As you mentioned before, our brain is our biggest sexual organ. So I was wondering because I've read that COVID had effects on some people's brains. Have you know about a patient with COVID affected their sexual stimulation or something like that?
Can you? I'm having trouble hearing you clearly. It's kind of like staticky.
So what I think what she asked was,
is it?
she was pointing out, you made an observation earlier about how the rate of sexual dysfunction and erectile dysfunction has increased throughout COVID. How does that tie into our brain being the primary sexual organ, and what factors from that whole pandemic do you think contribute to this worsening rate of dysfunction?
Oh yeah, that's a great question. Well, with the pandemic, you have to stress, right? You have to stress, so that will that will affect the brain area. But they have an endothelial inflammation. It causes the blood vessels to constrict, and therefore limiting blood flow to the penis from the pudendal arteries, and therefore that's how it can contribute to ED. Does that make sense?
Yeah, thank you. Thank you so
All
much.
right, thank you for the question.
Dr. Truong and Mo here. I had a question. So a lot of your patient experiences that you presented today were what seemed to be with cis men and women. I was curious if you had any experience with transgender people approaching you in your clinic, and what sort of issues they may have presented with, or any sort of insight you may have.
Right. Unfortunately, I don't treat or see transgender, and I really mainly focuses on men and biological men and female.
The combination of, heard countless anecdotes of people that I know who take these phosphodiesterase inhibitors, and they find that they can't perform without it, and there's certainly a psychological aspect to that. What else, if I have a patient that's coming to me and just saying, maybe he has all the metabolic syndromes and he has erectile dysfunction, and I want to avoid using these PD-1 inhibitors, and let's say I don't have the capacity just yet to do Regen Med, what's the first things that you would recommend to them?
Right. Great question. And remember, patient will only tell you that they're taking medicine if you ask. Oftentimes they don't consider Viagra or Cialis as a medication, or they're embarrassed to put it down on their medication list. All right. So 80% of doctors do not ask men or female whether they have any type of sexual dysfunction. That's not part of their history, HPI. So you got to ask for it. And you got to ask them, are you on Viagra, first of all? And if they are on PDE5 inhibitor, explain to them what I just said, that if you're taking that, you're hijacking your natural response to have an erection, because an erection starts in the brain. Why is that? Because you have to have sensory stimulus from your senses, which is your eyes for visual, your nose for the smell, the taste in your mouth, your touch, what you hear, all those five senses, right? That's what stimulates the sexual response. And that goes to the brain, and then it stimulates, and then the emotional state that you're in. You're depressed or anxious, or you're distracted. Well, that combined with the emotional state. So those five senses is what stimulate the sexual response. If you just take Viagra, you're just bypassing the brain, the emotion, the nerve, the blood vessels, and you just go straight to the muscle, because what it does is that increases nitrous oxide in the there you go. Somebody moved it. So it's right here. Yep. Right. Yep. No. Right here. There you go. So you're bypassing, the brain, the emotion, the hormone, the nerve, and the blood vessel, and go straight to the muscle. And so if you keep on doing that, your brain, your body forget how to stimulate a sexual response. And over a period of time, if they keep taking the Viagra, the root problem as to why they have ED worsen because they're not addressing the root cause of the problem. So what I usually say is that I equate Viagra as if it's taking opioid pain medication for pain, for back pain. So it's a short term solution, but it's not for long term, and it ends up not giving you any type of improvement for long term, and it bring you to a black hole that you don't want to go into, because we know after Viagra, after about 5 to 7 years, it doesn't work anymore because the underlying problem worsened, and that there's more psychological component of dependency on the medication than they think it becomes a crutch. So Viagra becomes a crutch for a man. He thinks that he can't perform without taking Viagra, when indeed he does. I'll give you a story. I have a 31-year-old Navy officer comes in to see me, and he has been having a fine erection, and then within a month he couldn't get an erection anymore. I went to see the doctor in the Navy, and he was given a Viagra to take. He took it for about a couple of weeks, and then after the third week, it doesn't work anymore. It just does not work. And the doctor said, well, just live with it, And so he came to see me. He said, I'm 31 years old. I just got married a year ago. I cannot not be functioning like this. And with that type of history, and he's a healthy male with no comorbidity or metabolic condition, it most likely is more stress or psychogenic. So I told him, I said, you're young. I even did a penile Doppler ultrasound on him. I didn't talk about that, but I also do ultrasound guidance injection. So I do a penile Doppler ultrasound. His blood flow was great, arterial and venous blood flow. It's great. So I told him, I said, I don't see any reason for you to have ED. And at this point, it's more anxiety at this time. So I told him, stop taking Viagra and for a week, and see what happened, because I reassured him physically, there's nothing wrong with him. Lord and behold, he come back and see me in 3 weeks and go, you know what? I'm able to get an erection now without Viagra because you told me there's nothing wrong with me physically. All right, so that just shows you how powerful the placebo effect is. How powerful your mindset and your psychology of your mindset can influence a physiological response.
Yeah.
You
Wow.
see that? I'm reassuring.
As a practicing physician myself, who is going to be taking a deep dive into regenerative medicine, what would you say is the best way for someone like me to get involved in doing these kinds of treatments?
Okay. All right. Well, the best way is to learn from somebody that can teach you the right way to do it, right? Just learning how to do a pudendal nerve block, correct way of injecting PRP into the penis as well as the vaginal area. I have taught many doctors that have been doing interventional pain management that have literally missed the clitoris and missed the G-spot after having several tries. and they come to my office and I teach them with live models. It's probably one of the most complicated injections you're going to do. I think that injection of clitoris and the G-spot in a woman is even harder than trying to do a foraminal nerve block, because it's a slippery area, and it's not an anatomy that you're used to seeing, and
it's so variable,
and you use a very small needle. And every woman is a little bit different. And so, learn from somebody that does it, and giving you the appropriate protocol to do it, and know that it's actually much easier than even interventional pain. Like I said, I used to do all that, but I stopped doing all that because my back hurt, my neck hurt. I don't want to expose myself to the radiation anymore.
Yeah, that makes sense. That makes sense. Well, thank you, Dr. Truong. I really, really appreciate this. This was hands down our most unique and most engaging lecture yet. So we
Thank you.
truly, truly are grateful. Thank you so much.
Oh, thank you. I'd love to come back again and talk about other topics, because I'm very passionate about the topic, because I feel that people are suffering from condition that could be reversible. Men and women,
It's so universal,
we can
too.
make such a big impact.
So one last thing before we go, Dr. Truong, if everybody could face towards the back of the stage, I want to take a quick selfie with everyone.
Face the back of the stage. Oh, right. Everyone turn selfie.
All right. We almost got everybody. There we go. 1, 2, 3, picture time. There we go. Beautiful.
Yeah, we even got the clitoris and the penis on there. Yay! I love that picture. Oh, please send me this picture. I want to put it on my social media and show it to my patients.
Absolutely. I have a whole bunch of pictures that I'll be sharing with you, with everybody here, actually.
Oh, that's awesome.
Yeah. All right. Thanks so much, everyone. We will see you guys here next week. Take care.
All right. Thank you.
Bye-bye.